Hello and welcome. Today we're diving deep into a lung disease called tuberculous pleuritis. This condition involves inflammation of the pleura, the lining surrounding the lungs, caused by the bacterium that causes tuberculosis, or TB. So, what causes tuberculous pleuritis? Well, the primary culprit is Mycobacterium tuberculosis. This bacterium typically reaches the pleura in one of two ways. Most commonly, it spreads from a nearby lung lesion, where TB is already active. Less frequently, it can occur through hematogenous spread, meaning the bacteria travel through the bloodstream from a different location in the body to the pleura. Immunocompromised individuals, such as those with HIV, are at higher risk. Let's break down the pathophysiology, how the disease develops. When Mycobacterium tuberculosis reaches the pleura, it triggers an immune response. This response leads to the accumulation of inflammatory cells and fluid within the pleural space. Initially, this fluid is often serous, meaning it's clear and watery. However, as the inflammation progresses, the fluid can become exudative, meaning it contains more protein and inflammatory cells. Granulomas, which are collections of immune cells attempting to wall off the bacteria, may also form on the pleural surface. Over time, these granulomas can cause thickening and scarring of the pleura, which can restrict lung expansion. Regarding epidemiology, tuberculous pleuritis is most prevalent in regions where tuberculosis itself is common. These areas often include developing countries and regions with limited access to healthcare. Populations at higher risk include individuals with compromised immune systems, those who have been exposed to TB, and people living in crowded conditions. Though less common in developed countries, it remains a concern, especially among immigrants from high-prevalence areas and immunocompromised individuals. Now, let's talk about the signs and symptoms. The most common symptom is chest pain, which is typically pleuritic, meaning it worsens with deep breathing or coughing. Other symptoms include shortness of breath, also known as dyspnea, a dry cough, fever, night sweats, and weight loss. In some cases, the amount of fluid accumulation in the pleural space, called a pleural effusion, can be substantial, leading to significant respiratory distress. Diagnosing tuberculous pleuritis involves several steps. First, a thorough medical history and physical examination are essential. Imaging studies, such as a chest X-ray or CT scan, can help visualize the pleural effusion. A thoracentesis, a procedure to drain fluid from the pleural space, is crucial. The pleural fluid is then analyzed for various characteristics, including protein levels, cell counts, and the presence of Mycobacterium tuberculosis. A pleural biopsy, where a small sample of the pleura is taken for microscopic examination, may also be necessary, especially if the initial tests are inconclusive. This allows for the detection of granulomas or the direct identification of the bacteria. While there aren't specific distinct types of tuberculous pleuritis per se, it can be classified based on the stage of the disease and the characteristics of the pleural fluid. It's generally categorized as either early or late stage, depending on the amount of pleural thickening and fibrosis. Additionally, the fluid can be classified as serous, fibrinous, or purulent, depending on its composition and the presence of inflammation. Treatment for tuberculous pleuritis primarily involves anti-tuberculosis medications. A standard course typically includes a combination of drugs, such as isoniazid, rifampin, pyrazinamide, and ethambutol, administered for several months. In some cases, corticosteroids may be added to reduce inflammation and prevent pleural thickening. If the pleural effusion is large and causing significant respiratory distress, therapeutic thoracentesis, where the fluid is drained, may be necessary. In rare instances, surgery may be required to remove thickened pleura or address complications. Preventing tuberculous pleuritis focuses on preventing tuberculosis itself. This includes vaccination with the BCG vaccine in high-risk populations, early detection and treatment of active TB cases, and public health measures to control the spread of the disease. Individuals who have been exposed to TB should undergo testing, and if indicated, receive prophylactic treatment to prevent the development of active disease. The prognosis for tuberculous pleuritis is generally good with prompt and appropriate treatment. However, delays in diagnosis or inadequate treatment can lead to complications such as pleural thickening, lung restriction, and chronic respiratory problems. Recent research has focused on developing more rapid and accurate diagnostic tests, as well as shorter and more effective treatment regimens. Investigations into host immune responses are ongoing, aiming to identify potential targets for adjunctive therapies that can improve outcomes and reduce long-term complications. Thank you for joining me on this exploration of tuberculous pleuritis.